The primary objective of periodontal pocket surgery is to secure a trimmed, often coronally displaced mucoperiosteal flap in a precise position. This position must be held stable for 7 to 14 days. If the flap is not tightly adopted to the tooth, a microscopic break remains open between the hard root surface and the healing connective tissue. This gap allows gingival epithelial cells to begin a rapid, early apical migration. These flattened cells creep downward along the biological surface of the root, physically blocking the slower-moving connective tissue from reattaching. Successful healing requires the exact opposite. Tight adaptation of the flap seals that gap, giving the connective tissue the time and physical contact it needs to properly bond to the root. The primary mechanical tool used to enforce this tight adaptation is the surgical suture, but the oral cavity is a highly mobile, bacteria-rich environment. Standard surgical closure techniques are insufficient here. Securing tissue in this space requires highly specialized microhardware. Periodontal suturing is a precise biomechanical intervention. It is engineered specifically to dictate cellular-level healing and prevent tissue necrosis. Every incision in the mouth faces an immediate environmental challenge, the exceptionally high baseline bacterial load of the oral cavity. To manage this risk, we have to look at the structural design of the suture material itself, which falls into two primary categories: multi-stranded polyfilament threads and single-stranded monofilament threads. Polyfilament materials, like silk, possess high capillarity. Capillarity is the ability of a liquid to flow in narrow spaces without the assistance of external forces. This high capillarity creates a clinical danger known as wicking. Bacteria use microscopic gaps in the braided structure as a pathway to travel from the contaminated oral cavity deep into the sterile surgical wound. The solid surface of a monofilament thread blocks this pathway entirely. Manufacturers attempt to solve this by coating polyfilaments to create a pseudomonofilament, but this is a flawed workaround. The mechanical stress of passing the needle and tying the knot breaks this coating. Fragments flake off and deposit into the tissue, where they elicit a localized foreign body reaction and increase the risk of infection. Therefore, the required standard for periodontal thread is strict. The material must be extremely inert and non-adhering to the surrounding tissue. The ideal materials that meet this standard are non-resorbable, monofilamentous synthetic plastics, specifically polypropylene, sold as Prolene, or polyamide, known as Ethylon. The choice of thread architecture directly dictates the surgical site's immunological response and its overall susceptibility to postoperative infection. Delivering that thread requires an instrument divided into 3 anatomical zones: the swage, the body, and the point. The swage is the connection point between the needle and the thread. Older, eyed needles force a bulky, double-layered thread profile through the tissue. Modern atraumatic needles utilize a press fit or laser-drilled swage, creating a seamless, single-diameter profile. This seamless connection is mandatory to minimize the diameter of the puncture tract left behind in the gingiva. Moving down the instrument, the body of the needle must be flattened. This geometry prevents unwanted rotation or twisting when the needle is gripped tightly by the surgeon's needle holder. This image illustrates 4 needle curvature profiles. The point's curvature dictates the working angle when navigating confined spaces. Of these options, the 3/8 circle curvature is the geometric standard for periodontal surgery. Its rotational arc perfectly matches the limited spatial access around the teeth. The final component is the tip configuration. Standard cutting needles are designed for coarse tissues and can easily tear delicate gingival margins. To prevent this, periodontal surgery relies on the sharpest alternatives: reverse cutting needles with precision tips or spatula needles with microtips, both designed for atraumatic penetration. Optimal needle geometry is an engineered prerequisite to ensure the surgical flap survives the physical trauma of being sutured. The absolute cardinal rule of periodontal suturing is the avoidance of excessive mechanical tension on the approximated tissues. The immediate visual warning sign of excessive tension is tissue blanching, where the gums turn white around the suture. Blanching indicates a complete cutoff of local vascular supply. If blood vessels are crushed, the tissue undergoes necrosis and dies, leading to complete suture loss. The tension placed on these tissues is secured by the knot, which consists of 3 parts: the loop, the knot itself, and the ears. The ears are simply the cut ends of the thread. Securing this structure typically requires either a standard square knot or a surgeon's knot. Because the ideal synthetic monofilaments we established earlier are completely smooth and low friction, they are prone to slipping. A surgeon's knot, utilizing double throws, is mechanically required to lock these inert threads in place. Once the knot is selected, the surgeon must choose a spatial configuration, categorized into interrupted and continuous patterns. This image displays an interrupted pattern. It utilizes a single isolated loop to provide discrete tension control directly between two specific teeth. Conversely, a continuous pattern uses a single thread to distribute tension evenly across the buccal margins and interproximal spaces of an entire quadrant. Regardless of the pattern, strict spatial rules apply. Sutures must never cross over incision lines, and they must not penetrate too close to the delicate interdental papilla to avoid tearing the tissue. Surgical success requires a continuous, real-time calculation. The clinician must balance the mechanical security of the knot against the strict perfusion limits of the local blood vessels. All of these mechanical and biological principles culminate in the modern standard of periodontal microsurgery. This chart shows the extreme specifications required for this work, utilizing precision 3/8 curvature needles paired with ultra-fine threads ranging from 7/0 down to 9/0 gauge polypropylene. However, there is a fundamental limitation to these advanced suturing techniques. They only stabilize soft tissue. When periodontitis causes severe bone loss, the underlying tooth roots lose their structural support and become highly mobile. If the underlying tooth shifts under normal occlusal chewing forces, even the most perfect microsurgical soft tissue flap will tear and fail. This introduces the required adjuvant therapy for hard tissue instability, periodontal splinting. This diagram illustrates a splint, a mechanical appliance that rigidly joins multiple teeth together. The intersecting MB axes show how this appliance distributes occlusal forces across a wider surface area to reduce the burden on any single tooth. The biological goal of splinting is to provide an immobilized foundation. It allows the periodontal ligament to reorganize and heal while the soft tissue flap repairs itself. Long-term periodontal survival requires the clinician to master two distinct physical domains: the macromechanical stabilization of the bone and tooth, and the micromechanical closure of the surrounding tissue.